Okay. Good morning, my dear colleagues. It's a great pleasure to be here today. Thank you, Dr. Singo. She's not here, and for all the organizing committee. I'm talking today about the aggressive ROP. Aggressive ROP, you have to take quickly the classification as mentioned before depends on the location, severity, and the extent, the presence of plus or pre-plus, and the aggressive ROP. Talking about the aggressive ROP, I'll just talk quickly about the plus disease, defined as dilated torches as mentioned before today, indicate aggressiveness of the disease, required prompt treatment, and its presence makes turning point during the observation. Which is more important, the venous dilatation or the arteriolar tortuosity? The arterial tortuosity usually starts first. It's the early sign of the plus disease, more specific to active disease, often appears before the venous dilatation. So arterial tortuosity starts, then venous dilatation follows. Presence of active or not active disease is important that these are the hints of activity. Progressive arterial tortuosity, the pre-plus or plus, associated ridge leakage, the premenstrual age usually less than 45 weeks. So going to the aggressive ROP, previously known as the aggressive posterior ROP, a severe rapidly progressive form usually occurs in posterior zone 1 and 2, occurs extreme preterm with risk factors. Characteristics, they are flat, prominent plus disease, flat or absent ridge as mentioned by Dr. Singol. Rapid progression, urgent treatment is needed as it does not follow the usual staging of the disease. The aggressive ROP, previously, according to the newest international classification, previously known old term aggressive posterior ROP, is location based, so it was describing the posterior zone only. The new term, according to the new ICROP, is behavior based, so aggressive form that can happen posteriorly and more anteriorly. So this diagram is showing the phases as mentioned today before, but I'm just seeing the diagram. You will see the importance of the biomarkers. So why biomarkers is differ or important for the aggressive or progression of ROP? Because it predicts the infants that will develop severe aggressive ROP. It can identify the high-risk infants before the clinical sign appears, guide the timing and intensity of treatment. We have angiogenic biomarkers, so briefly the VEGF, the insulin growth factor 1, and the erythropoietin, how it reflects on ROP. The VEGF often markedly elevated in the vitreous and the aqueous human, suggesting active stage anti-VEGF directly targets it. Low insulin growth factor is low, predicts severe ROP, as the insulin growth factor at the low level delay the vascular growth to avascular retina. The erythropoietin is elevated in aggressive ROP, so low IGF-1, high VEGF and erythropoietin, high risk for proliferative aggressive ROP. The inflammatory biomarkers also, the insulin growth, the interleukin 6, interleukin 8, tumor necrosis factor, they are elevated in sepsis, necrotizing enterocolitis, the inflammatory pulmonary disease, significantly higher in serum and vitreous of aggressive ROP. The C-reactive protein is elevated before the aggressive ROP. The MCP is elevated in plasma, indicating microglia activation in the retina. So ROP is not only a disease of hypoxia, but also inflammation has a role. This was discussed in multiple papers, as this paper, evaluation of time dexamethasone eye drops to prevent the proliferative retinopathy of prematurity. The blood changes also is very important as a biomarker. The hemoglobin, anemia leads to retinal hypoxia, VEGF surge. The hematocrit, rapid hemoglobin change, transfusion, oxygen instability. Actually, this is a very important point, this about the transfusion part, because in our practice, a lot of times you find this dilemma of having a baby with severe aggressive ROP that needs a blood transfusion and history of multiple blood transfusion before, and actually you need to know whether you're going to inject before the next transfusion or no, because after the transfusion sometimes the condition gets worse. The platelets regulate low counts and controlled angiogenesis. The white blood cell count, inflammation, cascade contribute to the ROP pathogenesis. So multiple transfusion, iron deficiency, anemia all alter the oxygen balance, impacting severe ROP. How to prevent it? We target the oxygen, the blood components, the nutrition, the inflammation. So avoid higher fluctuation, low mean oxygenation, avoid early loss of hemoglobin, weight loss, and inflammation treated very aggressively. The treatment, either we have anti-VEGF, laser, or combined. So according to the BTROP, Rainbow, and Firefly, they all mention the importance of intravitreal injection and how it is better for the posterior zone or aggressive ROP. So this is an example of aggressive form or posterior aggressive ROP, and this is the baseline, and this is 4 months later after intravitreal injection and laser. In this case, I lasered just the peripheral part of zone 3 with the injection, not all the avascular area. This is another example. Here's the baseline. Then in 4 weeks post-injection, regression happened, but unfortunately, later, 5 weeks later, recurrence appeared again, and large avascular retina, re-injection again. As you can see here, there is a peripheral avascular retina with again recurrence again, so it was lasered later on. This is another example also of aggressive ROP injection. We have the peripheral avascular retina that needs follow-up. This is also an aggressive ROP that was treated with only laser, and this is why injection is better, because with lasering all the avascular retina, you can see here the dragging of the macula and the thick fibrovascular membrane. Now we're talking about the oxygen-associated retinopathy. It mimics the ROP, but it can happen in a totally vascularized retina. So it has also a hyperoxic phase and hypoxic phase. In the hyperoxic phase, high oxygen exposure led to cessation of the retinal vasculature, regression of immature capillaries, and vasoobliteration maybe of vascularized retina. In the hypoxic phase, avascular retina becomes hypoxic, abnormal vessel growth. So long period of early hyperoxic exposure, unstable fluctuation oxygen level, vascular obliteration, and neovascularization. This is a diagram showing the obliteration, the neovascularization of the oxygen level. Oxygen-associated retinopathy can happen in full-term infants exposed to supplemental oxygen. Hyperoxia suppresses the VEGF, vasoobliteration, and rebound neovascularization. Resembles ROP but develops immature retinal vasculature. Risk factor: excessive oxygen, hypoxia, sepsis, mechanical ventilation, fluctuating oxygen saturation levels. The fundus finding: posterior pole vessel dilatation and tortuosity, ridge-like demarcation. It can happen all in vascularized retina. Within the vascularized retina, you can see an island of this ridge, flat neovascularization, retinal hemorrhage, and whitening. The prevention is strict oxygen control, target oxygen saturation, minimizing the fluctuation, growth support, use phase-based targets, and requires long-term follow-up even after discharge. This is an example of large infant that was released from the NICU, then returned back and exposed to high oxygen levels. As you can see, with the starting of development of the tortuosity and ischemia of the periphery, and demarcation line in the area between the vessels where capillary dropout started to happen. With oxygen control, treating the general condition and hemoglobin loss in this patient, 2 weeks later, the tortuosity is less, the capillary dropout improves, and this is 4 weeks later with complete disappearing of the tortuosity and improvement of the condition. Can oxygen oxygen supplementation be a treatment for some cases of ROP? A change in oxygen supplementation can decrease the incidence of retinopathy prematurity, as mentioned in multiple studies or papers. Lower oxygen target at early gestational age and higher oxygen target at old gestational age decrease the severity and incidence of ROP while inducing normal retinal development. This was discussed in multiple papers. A change in oxygen supplementation can decrease the incidence of retinopathy prematurity in multiple papers, as you can see. And usually they target the babies when they lower the oxygen level at the early stages and then increase the oxygen above 95 to 100% when stage 2 started to develop in these children. Thank you.